And I'm going to go ahead and share my screen with you guys. Let's get into Canvas here and let's take a peek at what we're doing. All right, can everybody see my screen? Awesome. So right now I'm in week 6. That's the week that we are in. And you guys can see everything that you have due this week underneath this module, okay? The modules, I'm not sure how Professor Luminoso had it set up for you guys at the beginning of the semester, but they are supposed to unlock for you on the Sunday night of the module of the week that we are going into, okay? So you guys should not have access to week 7. You guys should not be able to work ahead. So those modules are not going to unlock for you until this Sunday night at midnight, okay? Um, so that's kind of why I had some people asking like why they couldn't like access certain assignments next week. You're not supposed to be able to see the assignments for next week. We're supposed to stay in week 6 and then you go as it unlocks for you throughout the course. Okay, so this week, you guys have your second, I believe, NCLEX questions or the Saunders assignment. Okay, I've had a lot of questions about these, so I want to go through this more in detail with you so that everybody knows kind of what we're doing. So if you click into this assignment under Canvas, it gives you the step-by-step instructions on how to complete this assignment for this week. Okay, you are not going to be answering the same problems or the same questions that you had for the first NCLEX assignment. Every single time you have one of these assignments, it's under a different category, it's under a different subcategory, so you need to pay a really close attention in here in this directions on where you need to be going and specifically what subcategories you need to be answering questions in, okay? So you're going to come in, you're going to be redirected to the NCLEX RN examination site. You're going to select mode, exam, 50 questions. Then you're going to select your category. For this week, your category should be health problem. Okay. Your subcategory for this week is going to be maternity, and you should only be answering new questions. Okay. When you have completed all 50 questions, you can select end and tally session. You're going to select print results. You'll save this as a PDF, and then you need to use the proper file naming when you submit this assignment. Okay, so that's going to look like this with your name and with the date. All right. So the biggest thing for this is just paying attention to the categories and the subcategories that you guys are selecting because that's what I'm going to be grading. When I go in, I look, I see, okay, I go under health problem, I go to maternity, I see what you scored out of the 50 questions. That is how we calculate your score. That being said, if you get to 50 questions and you only answered like 60% of them correct, right? And you want to score higher on this homework assignment, you can go in and select to take more questions and you just keep going until you get the score that you want. Okay? This doesn't mean like if you submit it, I'll let you redo it and you have a whole nother assignment or whatever. You just have to take more questions when you're initially completing this assignment to get the grade that you want. Okay? Any questions about the NCLEX assignment? How to submit it? Okay. I had a lot of questions on that, so I wanted to make sure we went in and talked about that together. As well, under week 6, you guys have, let's see, you have your SimChart Placenta Previa assignment that will be due. That is an Evolve. You also have Quiz 4, which you guys will get to work on that after class today, and that is for homework, right? Open note, open book. Take your time on that. Make sure you're answering the questions correctly so that you can get a good score on this for your homework. Okay? So that is this week. Let's look a little bit ahead into week 7 because there's an assignment that I want to talk to you guys about that you will get access to on Sunday that is a little bit different than anything you've done yet this term. Okay? So next week you have discussion number 3. So what you need to do is on Wednesday night of next week, you need to have your initial response to the discussion posted in the discussion thread. Okay, your initial response needs to be posted by Wednesday night. You'll need to respond to 2 of your peers, And those should take place either on a separate day from your initial discussion or at least one other separate day you're posting, okay? And those responses to your peers needs to be submitted before Sunday, all right? So that's how you should answer the submit your discussion number 3. You have another sim chart, the external cephalic version sim chart that will be due next week. But what I really wanted to take some time talking about is this teaching plan assignment, okay? I went in and changed, it was brought to my attention this morning that the due date in here was wrong. So I went in and I changed the due date. It won't be due for you guys until the following Sunday at the end of week 7, okay? But it is a little bit more time consuming. It is a little bit more of a detail oriented assignment. So I wanted to kind of talk about it a little bit so that you had time to organize your week for next week because you guys have a lot going on because we also have unit exam number 2. All right, so next week's a little bit heavier of a workload week for you. So let's talk about this teaching plan here for a minute. So the teaching plan is typically what students will do is they'll make PowerPoints. Okay, that's usually the format of this assignment. That being said, you do not have to use a PowerPoint. You can submit this assignment as a detailed Word document. You can submit it as a PowerPoint like when you want to do like a poster board, you can submit it that way. What we really care about is that you're including all the information. So as long as all the information is covered and you guys have hit all the key points, I'm okay with whatever format you choose to use. What I will say is I've had I have had some students try and record them doing this as like a presentation, and it did not work well because it wasn't submitted correctly in Canvas and it was more confusing. So I would just try and stay away from that kind of a submission because it's usually doesn't work very well when we transfer it into Canvas. Okay. So anyway, the point of this is you are going to be the nurse and you're going to be developing a teaching plan for moms who are going home with their preterm babies. All right? So you are going to be basically making this presentation as something that you would present to moms in a hospital setting to give them good education before they go home with their newborn preemie baby. Okay? So what you have to do is you need to document a full head to toe assessment on a preterm neonate, focusing on both normal and abnormal findings. You need to identify at least 2 abnormal findings to consider as you develop your teaching plan. Okay, so I want you guys to go through the entire head to toe assessment on a preterm neonate. All right, and that can just be detailed like in order. Like you can do how you normally would do a head to toe, and you would just kind of write it in on your PowerPoint, say what is normal, any abnormalities that you see on this for this newborn or for this preemie, you could either highlight in red, you could have it in its own little section that says abnormal findings, whatever. But we need to see the full head to toe. We need to see that you document at least 2 abnormal findings. Then you're going to develop a going home teaching plan that includes the following: safety concerns for the preterm newborn, symptoms to report to the pediatrician, follow-up appointments, skin care and feeding, infection control, community resources, and support groups. Our rubric for how we grade these projects is I literally have it split up for me in all of these categories. Did the student address this category? Was it easily found? Was it highlighted on the teaching plan? So what a lot of students do is they have a PowerPoint and they have individual slides that go over each one of these topics. Okay? So you're going to make sure you include everything here and then you're going to submit it into Canvas. And then, as I kind of talked about, you can use a lot of different formats. The most common is PowerPoint or a Word PDF. Okay. It's worth 12 points. It's going to be available for you starting this Sunday, and it'll be due next Sunday for you. Okay. Underneath this assignment, you can go through and actually see the rubric and how I will be grading these, which will help guide you as you're completing this assignment. Okay? It's really not that bad. Students say that it doesn't take them very long. It's directly correlated to the stuff that we're going to be learning next week, anyways. So usually it's just really good review, and it also helps bring your homework grades up, okay? That being said, please, please, please make sure you are citing any of the resource, like wherever you're getting your information. Include that in a citations page at the bottom or the end of your presentation, okay? We have to submit, this is the only assignment that I submit to a plagiarism detector, okay? And it will flag if you don't have citations for your information. All right. So just make sure you're citing everything. If this is the second time that you are taking the class, please do a new teaching plan. Do not submit the teaching plan that you had submitted for the class before, okay? Because the plagiarism tool that we use will flag that and it will say that it's 100% plagiarized and I'll have to give you a 0. All right. So you have to go in and redo your teaching plan assignment if you've taken this class in the past. Okay. Any questions on this? Awesome. And like I have been since taking over the course, if you have questions, send me a message on Canvas and I try to get back to you within a day. Okay. All right. Let's go back to week 7. So yeah, week 7's a little bit heavier for you guys. If you need any assistance or anything, just reach out. We also have our second exam next week. Okay. So same thing as last time with your exam. You need to be in the Zoom, preferably earlier than 9 o'clock next week. We're gonna check everybody in, so you'll need your student ID. You're going to need to have 2 devices. So you'll have the Canvas pulled up on one device that you're testing, your testing device, and then you'll need to have Zoom on a separate device. Okay. I'll check everybody in. I'll see your ID. I'll ask for a 360 view of your space. Once you've been checked in, we ask that you don't get up and leave the screen. We'll all take our exam together. You'll have that 75 minutes. And then after exam, we jump right into content. Okay. So we do still learn after the exam next week. We are still going to be working in class afterwards. Okay. Talking a little bit about unit exam 2. If you guys did not see my announcement as far as like the exam reviews go, I have posted that. I have also included the PowerPoint that I'm going to be going over in my exam review, which my review is today at 3 p.m. Eastern Time for those of you who want to come. If you go into this announcement, exam 2 review schedule, you see all the different professors who are hosting reviews. I have the date and the time in here. All of this is Eastern time, okay? Um, as well as their Zoom IDs so that you guys can just copy and paste these into your Zoom whenever you want to go to a review session, okay? At the end of the day, I will be updating this announcement and including the recordings from all of the different professors' reviews so that you guys can go in and watch them. Okay? And yes, I am recording this right now. We are recording. My review is going to be recorded as well, and I will be posting it in here for you guys later this afternoon. Okay? I do have another class tonight from 5:30 to like 8:15. So if for some reason my review runs like extra long, I might not be able to post the recording until after class tonight. So just be on the lookout for it, but I will make sure that you have it so you can review it at least by the latest tomorrow morning. Okay. And like I said, this PowerPoint down here at the bottom of the announcement is what I'm going to be going through with whoever comes to my review. And it's literally just practice and NCLEX questions, okay? That deal with the topics that are going to be on your second exam. Okay. If anybody wants some extra tutoring before exam 2 and you want to go through the some stuff with me or you have extra questions, please reach out. This weekend I'm on call at the hospital, so I will try and schedule you guys times that we can do some tutoring. But obviously, if I get called in, I'll have to reschedule with you. But I'm more than willing to always meet with you guys and do extra stuff and do extra tutoring if that's something that you guys are interested in. So just let me know, okay? Um, the other thing, last thing, and then we'll jump into the lecture for this week. Um, Two things actually. So I went in and graded everybody's OB math calculations assignment. So the the way it was keyed in, I don't know how this happened. If you guys got like a 0 out of 12, it's because there was this whole thing where you had to type in the unit of measurement, and if you didn't, it automatically gave you zeros. Or if you typed in the unit of measurement, but you didn't put a space after the number, it gave you a 0. So I went in and fixed all of that. I gave you points back. If there was still a problem that you missed, if you go in, I put how to solve the problem and the solution in my comments, okay? So that you guys can review that so that you know where your mistake was and you can practice. I had some students ask me about extra about extra practice problems. Hold on one second. I had some people ask about extra where they can find extra practice problems for math. So let's see if it's still in here. If it's not, I will upload it for you. So here is an announcement that should have been put in at the beginning of the term. This is the math practice announcement. If you come into this math practice, there's going to be a whole bunch of different um, practice problems docs that you can use. Okay. This is a good resource for you if you've been struggling with math because I think there's at least 5 math problems on exam 2. So you definitely want to have that um, have that down. Okay. So that's where you can find some extra math work, some extra math problems for you. Um, Going into this week's announcement, again, it's the same as how it was formatted last week. You have my Zoom link, you have what we're reading this week, you have reminders about the quiz and your sim chart assignment, as well as the NCLEX assignment. And then at the bottom is the PowerPoint that we are going to be lecturing on this week. Okay? So I think that's really all I wanted to go through with you guys on Canvas. Does anyone have questions about homework, the grades that are already in right now, exam 2, anything like that?
I have a quick question. I did the wrong sim chart and it showed up as missing, but I did complete it. It was the preeclampsia. I did week 6 on accident, and I understand like if I don't get credit for it, are we able to get credit for it if it's missing, or is it just a 0?
You should be able to get credit for it if it's missing. So you didn't
Okay.
do,
I did the wrong one.
you just did the wrong one. Okay,
Yeah.
that's
Yeah,
fine.
I did week 6. I don't know. I don't know. I
Yeah,
apologize.
okay. I'll go in and see which ones you've done and which ones are still missing, and
Okay, cool.
you'll get credit for it.
All right.
The only thing is sometimes they will have to take off that 10% late penalty,
Yeah.
but if
Yeah,
you
I
get it
understand.
done, like that's fine.
Cool. Okay, thank you.
Yeah, no worries. Um, and I think that should be with almost all of your assignments, guys. So if like week 5, you're missing some stuff from last week, if you get it turned into me by Sunday, I'll still give you credit for it. You just have some late penalty, which is not much. It's like 2 points. So it's definitely worth just doing it anyway. Okay.
I have a question.
Yeah.
Um, do you, I see that like our exam two is not populated like in our grade book, and I know we do like what if grades. Do you ever like put them in the grade book or do you just do it as we do assignments?
You mean like how to figure out what you need on the exam?
Right.
So I can do that for you.
Hmm.
I also might be able to publish it so you guys could go in and mess with it yourself. But usually, if you're wondering like what you need, just send me an email and I can like plug it in on mine because I have like a little like test student that I can just like put grades in for. Um,
Okay.
if you're wondering what you need to get on it. But as far as like making it public. I usually don't post the exams or open that column in the grade book until like the day of the exam. So like next week.
Okay. All right. Thank you.
Hmm.
And quick question on just the chapters for exam two. So I know 11 and 12. Um, what are the others?
So it's going to be this week, 17. It's going to be week 5, which I don't remember the exact chapters. Let me pull up our syllabus.
Because I know it's just 4 through 6, but it's just been a little confusing.
No, that's fine. Yeah, that's fine. We can go through it real quick here. So let's go down here to where we have the weekly breakdowns because that makes it a little bit easier to see everything all right in front of us. Okay, so we're going from week 4. So that is going to be your 18 and 19. Week 5 is 8, so 18, 19, 20, 21. 5 is 11 and 12, and then this week, which is 17.
Okay.
Okay,
Mhm.
awesome. Yep. All right. So, if everyone is okay for now, we're going to go ahead and start the lecture. Obviously, if you have any other questions about homework or the exams, the exam reviews, anything like that, you can either stay after class or just shoot me a message in Canvas and I'll get back to you as soon as possible. Okay? So, let me pull up my PowerPoint here. And is everyone okay with how we did it last week, where we didn't really take a break? We ended a little bit early, and if you needed to like get up and go to the bathroom or get a snack, you just shot me a message. Is that fine with everyone still? Okay. Next week with exam weeks, I always take a break. Okay. We always have a little bit of a break after the exam to give people who take a little bit longer on their test time to go to the bathroom, get a drink, regroup before we jump right into lecture. But if we don't have an exam, I'm going to plan on us doing it this way for the remainder of the class, where we just go through the entire class, end a little bit early. Um, and then you guys can just like shoot me a message if you need to step away for a second. All right. Let me share my screen. Okay, so this week we're going to be talking about high risk labor and delivery birth complications. That's chapter 17 in your guys' textbook. Okay, so what is this going to be? What are we talking about today? Basically, we're going to be addressing the spectrum of complications that can happen during labor and birth. So this is including preterm delivery, membrane ruptures, OB procedures. So this is we're going to talk about cesarean section a little bit more in depth. We're going to be talking about versions. We'll be talking about vacuum assisted deliveries, provider assisted deliveries, assisted birth techniques. This is a big part of labor and delivery. This is going to be a big part of your guys' exam. So I want us to understand this content very, very well. So if you guys have any questions, interrupt me and let's talk about it more in depth. Okay. So moving right along here. We're going to jump into here first talking about preterm labor and birth. These definitions that you guys have on your slide are very, very important for you to know. These definitions and these guidelines are going to be key for you understanding the material, okay? So when we talk about preterm labor, what is preterm labor? That is what happens when a mom has regular uterine contractions that includes cervical changes before 37 weeks of gestation. Okay, and this is important. You need to have the uterine contractions, but you also need to have cervical change. Because I could have a mom come in who's 32 weeks and put her on the monitor and she's contracting every 2 minutes, but we monitor her for 4 hours and her cervix hasn't made any change. She's not in preterm labor, okay? Uterine contractions can be spurred on for a lot of different reasons, right? And they don't necessarily mean that they are labor, true labor contractions, right? These could be Braxton Hicks contractions. This could be because mom is dehydrated. This could be because she has an underlying infection or an underlying illness, like she could be sick. So simply having uterine contractions does not mean that a mom is in labor. That does not mean that she's in preterm labor. We also need to see cervical change. So if that 32-week mom comes in, she's contracting every 2 minutes and she's closed, her cervix is closed, she has no dilation, and then I recheck her in 4 hours and she's now 2 centimeters. That is cervical change with uterine contractions. She could be in preterm labor and we need to start some intervention. Okay? So know that definition. Preterm birth is a delivery between 20 weeks to 36 weeks and 6 days of gestation. So that is a preterm birth. Anything after 36 and 6 would be considered a full term delivery. Okay? So 37 weeks. Very preterm delivery would be any baby that is born before 32 weeks. This is when we see a lot of serious complications. This is when our morbidity rates are increased. This is when it's a little bit harder. We see increased NICU stays. We see prolonged hospitalization for both mom and baby. And this is a little bit more serious of a time frame. Okay. Late preterm would be 34 weeks until the baby is about 36 and 6 weeks. That's often underestimated in risk. So there is still risk with these deliveries. Obviously, this baby is still early. Fetal lung maturity is not completely has not been completed yet. So we still see high instances of respiratory distress, prolonged hospitalization, and NICU stay. All right. So I want you guys to be very familiar with these windows of time. Okay. Because we're going to handle and we're going to manage deliveries differently depending on the gestation. So we need to understand what is a very preterm baby, what is a preterm birth, what is a late preterm, because we're going to manage it totally different. Okay. From a weight classification standpoint, a low birth weight would be a baby that weighs anything under 2,500 grams. All right. This can be because we have a early delivery, right? It's a preterm birth. That's going to most likely, most of the time, be a small baby. Or it could be because of intrauterine growth restriction, which can be caused by a whole lot of things. We talked about this extensively last week. Like almost everything causes intrauterine growth restriction, right? Um, Drug abuse, sexually transmitted disease, infection in pregnancy, uterine abnormality, anything like that can cause intrauterine growth restriction. Sometimes having oligohydramnios, low amounts of fluid, that can cause intrauterine growth restriction. Um, Malnutrition of the mom in pregnancy, that can cause intrauterine growth restriction. So we need to understand that that is going to also change the way that we're taking care of these babies because if they're born and they're small or they come in and they have a growth restriction, we need to have NICU on standby because this baby is most likely going to need some help after a delivery. Okay. Um, as far as this birth classification part on this slide, we're talking about spontaneous preterm birth and then indicated preterm birth. So, a spontaneous preterm birth is something that happens without it being planned, obviously, from a medical standpoint. Mom comes in spontaneous labor. Maybe she had a uterine abruption because she was part of a motor vehicle accident. Something happened to trigger her to go into preterm labor. Okay. Um, this also could be without maternal or fetal illness, with or without maternal fetal illness. So it is just spontaneous. It's what it says, spontaneous. It happens without necessarily any reason. We don't really have an exact cause. We can't pinpoint why this is happening. An indicated or a iatrogenic preterm birth is done medically. It's medically indicated to resolve maternal or fetal risk. So probably the most pertinent example of this would be moms that have severe preeclampsia. Okay. From a maternal standpoint, that's what we're going to see most often with why we would take a mom early, why we would take a baby early. Because we know with preeclampsia, the only way to resolve this is to deliver the placenta because that disease process is derived from the placenta. So we need to deliver our placenta to fix our preeclampsia. Okay. From a fetal standpoint, we could be taking a newborn early for a lot of different reasons, okay? Intrauterine growth restriction is one of them. If baby is not growing adequately and their growth is not increasing the way that it should be, mom's fundal height measurements are off. We have conflicting information as far as like our ultrasounds. This could be a reason to have a baby deliver early. Does that mean we're taking this baby at 32 weeks? No. Usually, if it's an intrauterine growth restriction, we're looking more towards that late preterm window. So, like, usually even almost closer to 37 weeks if possible, if the baby can withstand that. Another reason why we might take a baby early is if for some reason we see signs and symptoms of fetal distress. So we put them on the monitor, baby looks weird on the monitor, not having good reassuring fetal heart rate tracing. Um, or if baby has some other underlying condition that is going to need more intensive NICU care, sometimes we need to prioritize delivery and getting them into the NICU rather than continuing the gestation. Okay? So, kind of jumping into causes of preterm labor and birth, we talked about a little bit, a couple of them. One of the most common causes of preterm birth is infection. So, if mom has a genital tract infection, some type of intra-abdominal infection, periodontal disease can also cause preterm labor and delivery. So that's why we still tell moms, hey, go to the dentist twice a year. You know, you're still going to go to the dentist, just maybe don't get x-rays, but we need you to take good care of your teeth. Proper dental hygiene is very important with labor and delivery. Another infection that we'll talk about is called chorioamnionitis. That is infection of the amniotic fluid. That can cause preterm labor. Okay, that is one of the main infections that can occur close to the pregnancy. Okay, genital tract infections, that could be if mom has a new onset of an STD or she has one that has not been treated or is reoccurring. Okay, chlamydia, gonorrhea. Um, if she has a flare up of herpes, that can also cause preterm delivery, preterm birth. So these types of infections are common at 30 to 32 weeks. Another thing that can happen is if mom has a yeast infection, okay, which is unfortunately very common in pregnancy, or if she has bacterial vaginosis, those can stimulate uterine contractions. That can cause cervical irritation and that can lead to cervical change in preterm labor and delivery. So we need to educate our patients very thoroughly on, hey, if you're having itching, if you have foul smelling discharge, if you're having pain, having uterine fullness or anything like that, you need to come in and be evaluated because these infections can cause preterm labor. All right. Structural abnormalities. This is talking about uterine and cervical anomalies. Okay. So for those moms that have a bicrinate uterus, that heart-shaped uterus that sometimes has that like septum that splits it down the middle, they can be at a risk for a preterm labor and birth. Okay. They are also at risk for IUGR because that baby is usually typically growing in only one half of that uterus, right? So these are all things that we need to consider. That is why we do scans early. That's why we do these pretty in-depth anatomy and growth scans because we need to make sure that there's not any of these conditions that could be indicating preterm birth. Cervical anomalies, that could go back to our last week when we talked about cervical insufficiency. Is the cervix extremely viable? Is it friable? Is mom having unknown sources of bleeding throughout her pregnancy? Has mom had a history of early delivery or early births? You know, that kind of thing. We need to have that documented so we know that she's at a risk for preterm birth again. Unexplained bleeding, so bleeding after that first trimester without identifiable cause, that can sometimes cause preterm labor and birth because we don't know where that source of the bleed is. We don't know if it's cervical, uterine, vaginal. Where is this coming from? And it puts mom at a risk. Stress is a huge thing that can cause preterm labor, okay? Maternal and fetal stress. So, is like, what is mom's home life situation, right? Is she have support? Is she still working throughout her pregnancy? What kind of work is she doing through her pregnancy? Is she on her feet all the time? Is she working 40 plus hours a week? Is she, all these situations can cause moms to have preterm labor or signs and symptoms that they are going to be delivering early. Uterine overdistension. What do you guys think that that means? Uterine overdistension. What could cause uterine overdistension?
Big baby?
Yeah, a big baby, for sure. What else? Like if we're thinking, what could make our uterus stretch to the max point or beyond that?
Too much fluid also?
Yes, too much fluid, polyhydramnios. That is going to stretch our uterus to the max. Multiple gestation, twins. Okay, you got more babies in there, you're going to have a bigger uterus. Okay, so over uterine overdistension, what are some things that could be causing this uterus to stretch to the max point where it probably shouldn't go? Okay, the ones that we mentioned are the biggest ones. If mom has severe allergies or has an allergic reaction, that can send her into labor. Okay. And then decreased progesterone levels. So, like, that is usually what we're seeing with like really, really early deliveries where mom probably should have been on progesterone throughout her pregnancy and maybe she wasn't because this is her first and we don't know that she has a history of like going early or cervical insufficiency. So if she has decreased amounts of progesterone through her pregnancy and it's not going to sustain it all the way to 40 weeks, she could go into preterm labor. All right. And then what do we do in that situation? We document that. And then the next pregnancy, she started on progesterone replacement earlier in her gestation. All right, how do we predict and how do we prevent spontaneous preterm birth? So, as far as like diagnostic testing, a fetal fibronectin and a cervical length are the two most commonly used and most reliable indicators of preterm delivery and preterm birth. Okay, so what is a fetal fibronectin? We release a glycoprotein related to placental inflammation. Okay, so it's a swab. You put the swab up into the cervix, you swab around a little bit, and then you send it to the lab. If it is negative, if the swab comes back negative, this is going to reliably predict who is not going to go into preterm labor. Okay, and that's a little confusing. And that's why, like, yes, we use this, but honestly, our cervical length is probably what we're going to look at more. So we're looking for that glycoprotein related to placental information. If it's negative, that means the patient is not going to go into preterm labor. Who do we do these swabs on? We do this on any mom that comes in who's earlier than 37 weeks, who's having uterine contractions or uterine irritability. Who is showing signs and symptoms of preterm labor just to see, okay, what does the fetal fibronectin say? Is she having placental inflammation, yes or no? If it comes back negative, we can sort of rule out preterm delivery. A cervical length, like I said, is probably the more reliable of these two. It is done via ultrasound, transvaginal ultrasound. They go in and they measure cervical length. Greater than 30 millimeters in the second and third trimester is reassuring against premature birth. Okay, so they'll go in. A lot of the times we do a cervical length, usually at the anatomy scan, they're going to do a cervical length assessment, which is usually around like 20 weeks, is whenever they do the full anatomy scan of a fetus. But sometimes if moms have like a history of preterm deliveries, they may do it earlier, they may do it a little bit later. It just depends on what mom's signs and symptoms are, and how she's doing and how the pregnancy is progressing. So we need to know that if a cervix is measuring greater than 30 millimeters in the second and third trimester, that means that our likelihood of delivering early is low. Okay. Other prevention strategies. Health promotion and lifestyle modification. So, adequate nutrition during pregnancy, encouraging mom to get out and do some 20 to 30-minute exercises daily. Preconception counseling to identify correctable risk factors. So, that means, is mom a smoker? Okay, smoking can put you at risk for preterm labor and preterm delivery. Is mom using or abusing any other substances? That is what we talk about when we mean counseling to identify risk factors. Okay. If they are using any drugs or they are smoking, we're going to talk about an abstinence program. We're going to talk about stopping because, of course, that's what we prefer moms to do. If this is not a solution or this is not realistic for them, then we need to talk about other options. Okay, this could mean just monitoring them more closely and seeing them more frequently throughout their pregnancy. All right. Prophylactic progesterone for patients with a history of preterm birth or a short cervix. This is what I was talking about on the last slide, where if we have a mom who comes in and she has had every single one of her babies at 34 weeks of gestation, she might be a candidate for prophylactic progesterone, just to try and get her to go a little bit further into that gestational period. All right. We do not give progesterone out lightly because increasing the amount of progesterone in pregnancy can have side effects for moms that are undesirable. It can pose risk for the fetus. So we do not want to just be handing out progesterone like for fun. We want to see like what is mom's history, what is her how old or what is the gestational age that she's delivered her other children at, and kind of go from there. Okay. Progesterone is really effective in preventing preterm delivery, especially in moms who have history of preterm birth. So it is a very reliable tool that we will utilize if mom has that history, okay? But like I said, if this is mom's first gestation and she delivers at 32 weeks, we're not going to be able to do anything prophylactically for this pregnancy, but for the subsequent pregnancies, we have it in our history and we can do something a little bit sooner. All right. Um, and then this is just a little note about the FFN. Okay. All right. So, how are we going to, as the bedside nurses, recognize signs of preterm labor? How is a mom going to present clinically for us to be like, oh, I think this baby might be coming early. We need to do some intervention. Okay. So, like we had said earlier in this presentation, preterm labor is defined as regular uterine contractions with cervical change occurring before 37 weeks of gestation. And every patient is going to present differently, okay? And that is why preterm labor is something that is kind of difficult to pinpoint. It can be sometimes very hard to diagnose because not every patient's going to come in and make cervical change. Not every patient's going to have spontaneous bleeding. Not every patient's going to even have uterine contractions. So we need to be able to use our bedside, our clinical judgment to determine what's going on, okay? So they may only have one sign or symptom, but anything that is suspicious, a patient should always be evaluated, okay? Labor and delivery, usually most of the places I've worked at have been really great about, if there's any question, just come in. We'd rather you come in and be evaluated than just sit at home and wonder what's going on, all right? So, one of the main ones that we talk about is vaginal discharge. This is probably what we educate our patients on more thoroughly. This is what we are really seeing with a lot of preterm deliveries. So, this is a change in the character or the presentation of vaginal discharge. So, if mom is having normal vaginal discharge and then all of a sudden it becomes super watery, or it's really, really mucousy, or there's blood in it. Or say she wasn't having like hardly any discharge at all throughout her pregnancy, and then all of a sudden she has to wear pads and she's changing her pad almost every single hour. Okay. Those are things that we need to be evaluating because in my head as a bedside nurse, if someone tells me I've had an increase in vaginal discharge, it's kind of watery, it's maybe there's some blood in it, I'm thinking maybe her water broke, right? We need to check and make sure that her membranes are still intact. Or maybe there's an infection, which, as we learned earlier today, infection can pose a risk for preterm labor. Okay. Um, so, like we said, this change in volume can indicate that her cervix is also changing. If she has an increase in discharge, that could mean that we're having cervical change. All right. So, this always needs to be evaluated. If a patient is 30 weeks, are you going to perform a digital cervical exam on this patient? And why or why not? Checking somebody's, oh, go ahead, Lacey.
I was just going to say you can cause them to go into preterm labor, right?
Exactly. Yeah. So as a bedside nurse, I do not perform a cervical check on anyone that is earlier than 36 weeks of gestation without asking a provider. And even if a provider tells me, yeah, go ahead and check their cervix, I might ask them, would you rather come in and do a speculum? Come in and come and just visualize the cervix, okay? Anytime you are introducing something into the vagina and messing around with that cervix, you run the risk of sending a mom into preterm labor, especially if you're trying to feel for dilation. That can really irritate the cervix. It can cause uterine contractions. It can send them into labor. So we avoid it completely, okay? If a mom is having bright red, painless vaginal bleeding, are we going to perform a digital cervical exam? No, we're not. And why would we not want to? What are you thinking could be happening with this patient?
Maybe placenta previa or
Yes, excellent. Yes, we are worried that this mom has a placenta previa, undiagnosed. Because last week we learned with an abruption, we have that dark red vaginal painful bleeding. With a placenta previa, it's often painless, it's bright red, and it's a steady trickle. So if we see that, we don't want to check them because we run the risk of poking the placenta with our finger, causing some type of abruption and disturbing that even more. All right. So that's excellent. Yeah, we do not want to be doing vaginal checks on those patients. Okay. Another thing that we can see with preterm labor would be pelvic and abdominal pressure. So that what I was talking about, that pelvic heaviness, where mom's like, I just feel like full. It's hard to explain this because it's just like a sensation. There's not really anything besides mom's report. But if she says that she's feeling pelvic heaviness or lower abdominal pressure, like kind of feeling like she's got like the bearing down, like baby is like pushing down into her pelvis, this could be an early warning sign of preterm labor. Okay, like baby has dropped into the vaginal into position to be born. They're getting ready to come down and be born early. A low, dull backache. So a constant low-grade backache that differs from pregnancy, like usual discomfort. These can be contractions. If mom is complaining of a low, dull backache, especially ones where it's rhythmic or persistent, that can indicate that mom is having contractions. All right. And then obviously contractions themselves. If mom is having uterine contractions or she's feeling crampy or she's uncomfortable, that can be a sign or symptom of preterm labor. Okay. So regular or frequent uterine tightening, even if it's painless, along with like mild abdominal cramps. Sometimes the moms will complain of having diarrhea. Sometimes it's just independent. Um, and possible rupture of membranes are signs that we need to evaluate these patients right away. Okay? So these four things are the biggest things that we look for when we're recognizing signs or symptoms of preterm labor. The other thing that I'm going to throw in there is history. If mom has a history of preterm labor, that is a patient that we are going to want to watch closely because if mom has delivered early with her other babies, the likelihood of her delivering her subsequent babies early is a lot higher. Okay? All right. So risk factors for spontaneous preterm birth, which we kind of just talked about this a little bit. So we need to understand the clinical, behavioral, social factors associated with preterm labor, because this is going to let us prepare for this. We're going to be able to identify high-risk patients and put into action our interventions a little bit earlier and possibly prolong this gestation. Okay. So we need to look very closely at these patients' obstetrical and clinical history. So, have they had a spontaneous preterm birth before between 16 to 36 weeks of gestation? Have they had genital tract infections, colonization, or instrumentation? So, like, have they had histories of STDs? Have they had BV in pregnancy? Have they had reoccurring yeast infections? What does this patient's history look like as far as that is concerned, right? Do they have a uterine anomaly? Do they have that bicrinate uterus? Do they have a septum? Do they have two separate uteruses? Where is our baby developing? Where is baby growing? Have they had unexplained vaginal bleeding during the current pregnancy? Okay. And this could be first trimester, second trimester, third trimester. Anytime a mom has complained or has had unexplained vaginal bleeding during a pregnancy, they are at risk for preterm birth. If they are pregnant with twins or triplets, multiple gestation immediately increases your risk of delivering early. Okay. Um, is this baby a product of reproductive technology, IVF, assisted reproductive technology? Anything like that can also increase our risk for preterm delivery as well. Okay. And then how is mom's teeth? It's so weird that like teeth are tied in so closely with preterm labor, but it really is a thing. So how do they have periodontal disease? Are they regularly seeing a dentist? That can indicate to us if mom is going to go into labor early. So the behavioral and social risk factors are a little bit more self-explanatory. So are they smoking cigarettes or abusing another type of drug during pregnancy? That is going to increase their risk of preterm birth pretty exponentially. Are they underweight? So, does mom have a history of an eating disorder? Does she currently have an eating disorder? So, that we were going to need to get her into therapy or in counseling right away for that, get her some treatment because we also need her to be able to sustain the pregnancy from a nutritional standpoint, right? So, is she underweight? BMI is under 19, or is she obese? A BMI greater than 30? Anything like that can put us at risk for preterm deliveries. Limited education and socioeconomic status. Do they have access to adequate nutrition? Right? Are they educated enough to know the signs and symptoms of preterm labor? Okay. Do they have means of transport to get them to the hospital if they are showing signs and symptoms of preterm labor? Okay. These are all questions we should be asking them at our OB prenatal appointments, making sure that they are supported, making sure they have the resources that they need to adequately support themselves in their pregnancy. Is this an instance where we have late prenatal care? I saw this so much in the Amish community because, they don't come to the hospital very often. They don't go and be seen and get doctor's appointments or thorough prenatal care. So we would have moms that would come into the labor and delivery unit. They are maybe, we don't know their gestation completely. We know maybe their last period, and we could try and figure it out, but they haven't had a single ultrasound. They haven't had a single blood draw, nothing. So we have no OB history on this patient. We don't have any clinical history on this patient. So we don't really know what we're getting ourselves into. So late entry into prenatal care also, why is that dangerous? Because we don't know how this pregnancy is progressing. If the mom has a uterine anomaly, we don't necessarily know about it yet, right? Because she hasn't had any ultrasounds, she hasn't had any scans done. So this can also increase our risk simply because we're not sure how this pregnancy is progressing. Like we mentioned before, high levels of stress can also increase our risk. Um, so that's important to know. African Americans have a higher rate linked, unfortunately, to systemic health disparities. So we need to make sure that this group of patients and this population is advocated for in the hospital. Okay, so that is our job as the bedside nurse. No matter the race, background, history of your patient, we need to be advocating for them. Okay, um, so that is something to keep in mind. And then down here we have this little note. No single risk factor is deterministic. A comprehensive, individualized risk assessment at the first prenatal visit allows us to be able to intervene early and improve our outcomes. All right. So that just goes back to our early recognition and early intervention. All right. So how we know now our risk factors, we know the signs and symptoms. How are we going to treat preterm birth or preterm labor? All right. And like I said, this is done depending on the gestation. This is done depending on mom's history, the history of the pregnancy, how it's progressing. All right. So we have our mom who comes in with her signs and symptoms. She says, I'm having a lot of pelvic pressure. I have a dull backache. My uterus feels like it's tightening. I'm not able to relax. I haven't been able to drink water. I haven't been able to sleep. All right. We put her on the monitor. She's contracting. We check her cervix. She's like a centimeter dilated. Um, for fun, let's just say she's 34 weeks gestation. Okay, so we're in that late preterm window. What are we going to do? How do we stop this if it's appropriate? We are going to use some medications called tocolytics. That's under the category tocolytics. These medications are specifically used to stop uterine contractions. They are used to relax the uterine muscle and stop our contractions. The number one that I have used at the bedside is this one, terbutaline. Terbutaline is a medication that we're going to give. It's usually an injection, and that is going to suppress uterine activity. These ones over here, it's all listed for you. It's not my time, the uterine relaxants, the tocolytics. So your indomethacin, yours is an NSAID. Nifedipine is a calcium channel blocker. We can use magnesium to suppress uterine activity. However, as we discussed last week, magnesium is mainly used to prevent seizure activity. It can sometimes stop uterine contractions as a side effect, but we don't usually use this simply just to stop contractions. Okay. And then the terbutaline. That is what we're going to use. Those are the four medications I want you guys to know can help relax our uterus. The other thing we're going to do is we're going to administer a steroid. We're going to be using that betamethasone, okay, which is a corticosteroid, which is used to promote fetal lung maturity. This is 2 doses of a medication given IM 24 hours apart to a mom, and it helps speed along that process and helps mature a baby's lungs. So that if we do deliver early, baby has less of a chance of having respiratory distress. It helps shorten NICU stays, and they usually do a little bit better at delivery. Okay. Mag sulfate. So we mentioned this is mainly used for seizure activity in a preeclamptic mom. Why would we also give it in the instance of preterm delivery? It can relax our uterus, but another reason we would do it is it prevents cerebral palsy in a baby. Okay, so that's another reason why we can give magnesium. It's a huge thing that we give for cerebral palsy prevention, especially in those really, really early deliveries. So it's a 4 gram loading bolus dose and then 1 gram an hour for 12 to 24 hours. It's a tocolytic and a neuroprotective agent. And this is usually done before 32 weeks of gestation if a mom is coming in with any of the signs and symptoms of preterm birth and delivery. And then, obviously, we're going to give moms antibiotics, especially if their water has ruptured. We're going to start them on antibiotics pretty quickly to prevent chorioamnionitis, which is that infection of the amniotic fluid, and prevent baby or sepsis or anything like that from happening for mom. Okay. If you are at a small facility like I am all the time, these patients we need to get them to a higher level of care if possible and if it's safe, right? So if a mom is already 6 centimeters and she comes in, she's 32 weeks, most likely we are not going to be able to transfer this patient. She is already too progressed from a cervical standpoint. We're going to have this baby at the hospital. We'll stabilize the baby and then we'll ship the baby when it is appropriate. Okay. But if a mom comes in and she's only 1 centimeter, she's contracting, we have her on magnesium, we have her on these other tocolytics, and we stop her contractions. But she's still like slowly progressing and we suspect preterm labor. We have the time that we can stabilize and transfer. Okay. We need to get them to a facility that has a higher level of care with a neonatal resuscitation team. Okay. All right, moving right along. So sometimes what can happen is premature rupture of membranes. So moms can their water can break early, and it doesn't necessarily have to be tied in with anything else or any other signs or symptoms of preterm labor. Okay, so PROM is their spontaneous rupture of the amniotic sac before onset of labor at any gestational age. Okay, so this could even happen at so this happened to me at 41 weeks of pregnancy. I went over with my baby and my water broke before I had any uterine contractions. All right, so that would be premature rupture of membranes. Um, Preterm premature rupture of membranes, that's PPROM. is whenever your water breaks spontaneously, and it occurs before 37 weeks of gestation. This carries significantly higher risk. Why would this be a higher risk at this point rather than, my situation where I was overdue? If a mom has her water break and she doesn't realize it and she's like 36 weeks, is that going to increase her risk for infection or severe like pregnancy complication? For sure. For sure. So, having a mom's water break whenever they're like 38 weeks or 39 weeks and they're not having any uterine contractions, like that's no big deal. We just send them and we bring them in, they go into labor. If a mom's like 34 weeks and her water has broke on its own, she's at a higher risk for infection. Baby's at a higher risk for infection following delivery and having a little bit of a NICU visit, a NICU stay. Um, we also can see some other types of complications which we have listed over here. That chorioamnionitis, like I had talked about, infection of the amniotic fluid, that is the most common whenever we have premature rupture of membranes. All right. Um, Now it's not, if a mom is like full term, okay, and her water breaks early and she's not having uterine contractions. In the past, they've said, oh, she needs to deliver before she's 24 hours. But that is not the case anymore. If she's receiving adequate prophylactic antibiotics, she can be in labor for longer, and it's perfectly safe as long as mom and baby are not showing any signs of infection. Um, that being said, we also really need to understand the signs and symptoms of infection in both mom and baby during when baby is still in utero. So for mom, that's your normal like fever, aches, chills, the normal signs of infection or illness in a patient. For baby, what you would see on the monitor typically is baby would be tachycardic if baby has an infection. If baby is sick or we're suspecting something like that, baby's heart rate is going to be sustainedly elevated. All right. So you guys need to know that for sure. Other complications that are associated with a premature rupture membrane would be a placental abruption. This can go back to infection as well. Infection can cause this as well. So we need to be aware of that. Cord prolapse. If a baby is really small, okay, and water breaks early, and the baby's head is not fully applied to the cervix because we're 33 weeks of gestation, we run the risk of that cord slipping down under baby's head and having a cord prolapse, which is immediately a cesarean section, immediately an OB emergency. Sepsis and intrauterine infection, big time. A hemorrhage and retained placenta, we see that a lot with these patients. And then occasionally pulmonary hypoplasia if the rupture occurs before 20 weeks. All right. Um, so all of these types of things can happen with our premature rupture of membranes in our patients. What is our care management? So, with any gestational age, we're going to assess for the risk of infection. Our infection is the highest concern. So, we want to see, like, okay, if patient is 34 weeks and her water has ruptured, is it safe to be giving her antibiotics, prolonging this pregnancy just a little bit longer, or do we need to deliver? Earlier than 34 weeks, we need to deliver this baby because we usually cannot keep away infection and treat them for long after their water has ruptured, right? Um, if water has broke, we also need to consider like baby's fluid levels are going to be depleted, right? That's going to cause all other sorts of problems. So we can maybe do an amni infusion where we put fluid back up into the uterus to sustain the baby. But, that is a temporary fixture. That is not something we can do for days and weeks on end. So usually these babies in this pregnancy needs to be delivered. Um, Greater than 34 weeks. Less than 34 weeks, we're going to do expectant care. We're going to maybe try to do some antibiotics. We'll be giving that MAG for that neuroprotectant agent for the baby. We're going to be doing NSTs. We'll be monitoring the patient. These are patients that are going to be hospitalized, right? They're not going to go home, like especially if their water has broke and they're early. We're keeping them in the hospital and we're going to manage that pregnancy for as long as it's going to be appropriate. Um, So, like I said, below 34 weeks, the risk of preterm delivery often outweigh infection risk, favoring expectant management with close surveillance. So, we need to also take into consideration how is our baby's lung maturity, right? Pulmonary maturity is going to help us with the timing of delivery. So, sometimes that just means mom comes in and she gets her 2 doses of the betamethasone, and we consider that sufficient, and then we have the baby. Okay. Other times that means, all right, this patient's 30 weeks. If we can prolong this gestation just a little bit longer, we're going to try. All right. All right, let's talk more about choreo. Choreo is one of those things, it's like what they talk to you about like C. diff. Once you have smelled it and once you have seen it, you will never forget what it looks like and what it smells like. Okay, choreo has a very, very distinct smell and it is not a pleasant one. So you usually know right away if a patient has choreo. Okay, this is a bacterial infection of the amniotic cavity. It usually develops after our labor begins, especially if mom ruptured prematurely. Okay. So mom is in labor or her water broke very early. That increases the risk for chorioamnionitis. All right. Like we talked about, we need to know what our signs and symptoms of infection are going to look like in our patients. So, mom is going to have a fever. Mom and baby are both going to have tachycardia. All right, their heart rates are going to be elevated. We are going to have mom complaining of uterine tenderness. Her abdomen, her uterus is going to be tender, especially like if you're pushing on it. Like I've had moms before with choreo where I go to put the monitor, like the ultrasound monitor on her belly, and she'll like jump like I just poked her or tried to start an IV. Like she'll be very, very tender, very sensitive to anything touching or being on her belly. Um, if she has that purulent amniotic fluid, that is definitely a warning sign. And then if baby's heart rate is elevated, if baby is sitting at like 180 beats a minute for a long time, I'm immediately going to jump to this. There's some type of infection. All right. Risks and management with choreo. So for our baby, this baby is at a high risk for pneumonia, bacteremia, meningitis, respiratory distress, and cerebral palsy. All right. For all of these things, they are going to be in the NICU. They are going to be in the NICU probably for a couple of weeks, getting antibiotics, getting treatment, getting fluids, having labs drawn, getting different medications to help with lung maturity and help with decreasing that risk for infection. For moms, if they have choreo, they are going to have a dysfunctional labor. They are not going to be having a normal uterine pattern. They're not going to have a normal uterine contraction pattern. This is going to cause labor dystocia, meaning that this labor is not going to progress as it normally would for a patient who is not having this infection. She also will present with some bacteremia as well. So we're going to administer broad spectrum antibiotics and we are not going to administer tocolytics. So if mom has an active infection, we are not going to be administering tocolytics because that could increase our risk for uterine rupture. Okay, so those medications we talked about to stop our uterine contractions, the indomethacin, the nifedipine, magnesium, the terbutaline, those immediately, we're not going to use those because that can increase our risk for abruption, and it's contraindicated whenever there's an active infection present. All right. So we talked about preterm labor, delivery, and birth. What are the risk factors associated with a post-term pregnancy, labor, and birth? So post-term now is defined as a pregnancy that extends beyond 42 weeks of gestation. And this comes with its own set of risk factors, right? Going early has risk factors, going too late has risk factors, all of that, okay? Frequent fetal surveillance is essential due to the elevated stillbirth risk. The further past a due date a mom is, the more increased the chances are for stillbirth. Why do you guys think that is? It kind of tells you and on the like fetal risk side a little bit. We've got an old placenta. All right. Do you think that placenta is oxygenating baby as effectively if it's a little bit older and it's tired? No, not usually. So, the reason that the stillbirth is an elevated risk factor for a post-term pregnancy, your placenta has a life expectancy, is the best way to put it, and it's that 40-week gestational period. Okay, that is when our placenta has the highest level of functioning. That's when the circulation is at its most effective. That is when oxygenation is at its highest. The older and the further past our due date, a placenta goes, our vessels are going to be constricting, the oxygenation is going to be depleted, it's going to be decreased, our circulation of blood flow is going to be decreased because of that constriction, because that placenta is old and it's tired. It's it's at its max. Okay. Um, so what does that mean for our baby? Baby is not going to be getting as much oxygen on the monitor. The baby might not have as much variability in its heart rate. Um, so we're going to see signs and symptoms of deoxygenation in this baby because this placenta is aging out. All right. That is the biggest risk factor with a post-term pregnancy. Okay. From a maternal standpoint, and post dates, we sometimes will see that labor dystocia, like I talked about with chorea, where mom's uterus is tired, it's over distended, it's at its max point as well. So we might not be having as effective uterine contractions. We might see stalled labor. We might not see contractions without medical intervention. So mom might not even have contractions on her own. We might need to administer IV Pitocin to get this patient's pregnancy and this labor on the roll. We could see perineal injury because baby, if it's post dates, the risk of having a macrosomic infant is higher, so we could have a big baby. Hemorrhage is a lot more common in a post-term pregnancy than in a, like, let's say 38-week pregnancy. Why would that be? Why do we see hemorrhage more often with a post-dates pregnancy?
Is it the same thing that the placenta and why can't I think of the it's older or it's weaker?
Yeah, so not from this standpoint with hemorrhage, it's more of a uterine thing than a placental thing, but yes, you're on the right track. So our uterus is, it kind of goes back to that a uterine overdistension. If you have a patient who's 42 weeks, that uterus is stretched to the max. We usually may see a macrosomic infant, a bigger baby. If that uterus is way, way, way big, it takes a lot more effort and contractility to return that uterus back to its pre-pregnancy state. Okay. So that means mom is at a higher risk for, we might need um, some medications post delivery to help that uterus contract, to keep that contraction happening, to shrink that uterus, prevent hemorrhaging, prevent excessive blood loss. Okay. Your uterus is tired, it's stretched to the max. Returning it back to its pre pregnancy state is going to take and require more effort, more contractions. And in a post dates pregnancy, sometimes that's harder to obtain because it's tired, it's over distended. Okay. We also see an increase in cesarean birth risk with these patients. And then obviously like fatigue and psychological distress. Okay, so mom is tired of being pregnant. She's way pregnant. Um, Sometimes though you have patients who, and I saw this a lot in Amish country, especially patients that had little to no prenatal care who come in and they don't know their gestational age. We don't know what we're looking at. We also have some moms who are extremely, extremely opinionated, and I do not want an induction. Okay. That is something that has been on the rise as of late, where moms do not want any type of medical intervention. They do not want an induction. They do not want Pitocin. So they are refusing medical intervention to the point that I've had moms come in at like almost 43 weeks of pregnancy. And, this placenta has totally maxed out. It is exhausted. Baby doesn't look very good on the monitor. We end up having a C-section, and they're looking at a totally different birth plan than what they initially wanted. Okay. So we need to educate our patients that, the risks associated with a medical induction are significantly lower than the risks associated with a severely post-term pregnancy. All right. This is a hard conversation to have, especially with moms who are like, I don't want any medical intervention. I don't want this. I want, and that's really hard to talk to them about this stuff. So we need to be caring. We need to be a little bit more we can't be judgmental or anything like that. We need to talk to them in a very practical way and say and stress highly on this is the safest option for you and your baby, right? Um, from a fetal standpoint, with risks for a risk associated for the baby with postpartum pregnancy, they are going to be bigger most of the time, which increases our risk for birth injuries. So, like a clavicle fracture with a shoulder dystocia. If the baby is really big and they're not coming down easily through the vaginal canal, and we decide that it needs to be an assisted vaginal delivery, so we're looking at a forceps birth or a vacuum assisted delivery, that poses risks for baby as far as birth injuries go as well, which we'll talk about that a little bit later in this PowerPoint. So all of those things can increase the risk for baby. Like we mentioned, that aging placenta, that is going to decrease our estrogen production. We're going to see deoxygenation of baby, decreased circulation of blood flow to the placenta and the uterus. Okay, and that poses a risk for our infant. Low amniotic fluid. Okay, that is something we see a lot in post-dates pregnancy, mostly because maternal system is starting to phase out of supporting this pregnancy, right? Because it has that gestational window. It gets to 40 weeks, right? 41 weeks is fine. Anything usually over 41 weeks, we see the maternal body system stopping the continuation of the pregnancy. They're not using as many of the maternal reserves to support the pregnancy as they had been earlier in gestation. Okay, so oligohydramnios, we're not producing as much amniotic fluid, so that can lead to cord compression because we don't have as much of a cushion around that umbilical cord. So we'll see decrease in the baby's heart rate if they're on the monitor, and that will cause hypoxemia in our infant. Hypoxemia in our infant after delivery, they have a higher risk of being in respiratory distress because they're already in a metabolic acidotic state. Okay, so we're going to see increased resuscitation of our infant, NICU stays, and support them. They're going to need more support from a respiratory standpoint following delivery. Okay. Meconium aspiration syndrome is another huge thing we see with postpartum pregnancy. This is what happens when baby has their first bowel movement in utero. So we have that like green or black um, coloring of the amniotic fluid, which indicates that baby had a bowel movement. If baby is coming down through the vaginal canal and they swallow a bunch of that meconium stained fluid, that is not good. That gets stuck in their lungs. Babies, especially if they already have immature lungs, if they're early and they've had some type of, well, we're talking about post-term, but if they're swallowing this fluid and it's sticky, they're gonna have a hard time oxygenating and converting carbon dioxide and oxygen, right? Um, Post-term, this is more common because baby is older, baby is bigger. Post-term pregnancy would be considered a high stress event for the baby. It puts extra stress on the infant, causing meconium to occur in utero. All right. Questions about post-term pregnancy at all, or anything really that we've talked about so far? All right, moving right along. So let's talk about dysfunctional labor or dystocia. I've already mentioned this a couple times in this PowerPoint, but I do want you guys to fully understand what we mean when we're talking about this. So this is what happens when there's a long, difficult, or abnormal labor caused by one or more of the 5 Ps, which we talked about. You guys should have talked about this, I think, in week 2, the 5 Ps of labor. Your power, passage, passenger, position, and psyche. So power is referring to our uterine contractions. In a dysfunctional labor or in a dystocia, mom is not having effective uterine contractions. This is going to be because of the primary or the secondary powers. So primary powers would mean usually mom's just not having any contractions on her own at all. All right. And this can be due to a lot of different things. All right. From a secondary power consideration, we are trying to give her uterine contractions, whether that's from medication or a Foley balloon or some other type of induction method, and it is still not producing an effective uterine contraction pattern. How do we know if our uterine contractions are effective? Is she making cervical change? If she's not making cervical change, our uterine contractions are not effective, which would be dystocia. Okay? From a passage standpoint, that is looking at mom's anatomy. Okay, how is mom's pelvic shape? Does she have some type of soft tissue obstruction? So does she have a placenta previa? Is her cervix really swollen? Or another uterine anomaly. When we talk about cervical edema, all right, this means a mom who has been in labor for a really long time, and typically baby is coming down in an asynclitic presentation, and it's causing mom's cervix to swell. All right. Usually, when we see this, it's like one sided. Like you'll go in to perform a cervical check, and one side of her cervix feels like really, really thin and fine. And then the other side of her cervix is like still really thick. It's swollen, stuff like that. That would be an indicator of labor dystocia. All right, that is not good. And then the uterine anomaly. So, does she have a bicornate uterus? Does she have a septum? All that kind of stuff. Okay. Um, that's what we mean when we talk about passage. Passenger, so from a fetal standpoint, what is our baby doing? Fetal malposition or malpresentation. So, like, is baby breech? All right. If it's a butt that is on the cervix, it's not as hard as a head. It's not going to cause as appropriate of cervical dilation or change because we're not putting the same amount of pressure on the cervix during the uterine contraction. All right. Same with if the baby's got a foot down there, right? That's not going to cause uterine cervical change because we don't have that appropriate um, widely spread pressure on the cervix to cause our cervix to change. All right. Cephalopelvic disproportion, that baby's head is not fitting well in the pelvis. All right. It's not coming down effectively. It's not going to be able to fit through the pelvis. That is going to cause labor dystocia. And then finally, position and psyche. Mom's stress hormone, so that cortisol, will act on the uterine smooth muscle, preventing cervical uterine contraction and cervical dilation. Sometimes we see this more with advanced maternal age. We see labor dystocia, dysfunctional labor. Sometimes, if a mom has had an epidural or any other type of anesthesia that can stop our uterine contractions, we might need to incorporate IV Pitocin or add other medications in to bring those contractions back for her. Okay. The other thing too is like if mom is in a position that is not favorable for her labor, so like if she's having extreme back labor, so we maybe are thinking that baby is in an OP position, a posterior position. It's not going to make any sense to have that mom flat on her back for her labor. She needs to be up in her hands and knees. We need to be turning that patient. We need to be moving her, rotating her so that baby can get in a more favorable position for delivery and give her the best chance of having a vaginal birth. All right. So these are all things as a bedside nurse where you're like, oh, my patient's been in labor for 12 hours and we've only made 2 centimeters of cervical change. Like, that's not effective. We need to look at our 5Ps and be like, okay, what part of this is causing labor dystocia or dysfunction? And then we need to try our best to try to rectify it and put her in different positions, do our other little nursing interventions to try and get her a more favorable outcome. Precipitous labor. These are the most crazy. Okay. These are when you are delivering the baby because the doctor doesn't make it in time. I've done that like 10 times now. And it's usually all with the Amish patients because they don't even realize they're in labor. They come in and they're totally stoic and their baby's crowning. And you're like, all right, well, here we go. So this is when you have a labor that lasts less than 3 hours from the start of contractions to the birth of the infant. This is very, very fast delivery. It's associated with hypertonic contractions and rapid fetal descent. Okay. We have some complications associated with this, as you can imagine. If we have this rapid, crazy delivery, there is going to be some complications following it. Possibly, not every time, right? Everybody is different, but a lot of times we see some complications. From a fetal standpoint, hypoxia is number one. This baby doesn't know what hit them, okay? They are stunned. They went from just hanging out in the womb, everything was fine and dandy, to all of a sudden uterine contractions are happening every minute. They're not having enough time to recover in between these contractions because they're happening so strongly and so quickly that it's going to deplete their brown fat stores. They're going to enter into an acidotic state and they're going to become hypoxic and need some resuscitation following delivery. All right. They can also experience some intracranial trauma from rapid delivery. So we can have some head injury because they're coming down through the vaginal canal so rapidly. All right. Maternal complications, the biggest risk factor with this one, and I want you guys to understand this is postpartum hemorrhage, okay? That is the last one on this list, but it's the biggest one that we see. All right, we'll talk about it here in a little bit. Um, Other ones would be uterine rupture. That is because your uterus is working so hard for such a short amount of time, but if it's hypertonic contractions, you have contractions every minute, and we're not giving that uterus adequate enough time to refill and to oxygenate in between each contraction, it can disrupt the uterus and it can cause and lead to a rupture. All right. Perineal lacerations is a big one. That baby's coming down so rapidly. We don't really have time for the most gentle of deliveries because we're delivering so quickly that we're gonna potentially have some pretty nasty lacerations. Okay. Um, I've had moms who have had precipitous labor who have had no tears or lacerations, and then I've had moms that have had fourth degree tears and lacerations, which is just terrible. Um, Another thing we can see is an amniotic fluid bolus, which is an OB emergency, okay? Because a lot of the times we're worried about this going to the lungs, all right? And so we need to have our moms monitored very closely following delivery because if we have an amniotic fluid bolus, we're going to see moms start to decline clinically. So they may have difficulty with their respirations. They may have increased respirations. They may have a hard time breathing. They may say they are feeling this impending sense of doom or having a lot of anxiety. Anything like that, we need to get some further diagnostic images and diagnostic testing to rule out an embolus. So, with a precip labor, I had mentioned that postpartum hemorrhage is what we're going to see more commonly. And this kind of goes back to that whole idea of your uterus is tired. Okay. Your uterus is worn out because it just did so much work in a very short amount of time. All right. Um, and so once that happens, after the baby's born, sometimes what we'll see in these moms is the uterus is like, okay, I did my job. My job's done. And then we don't have uterine contractility in the postpartum period, which increases our bleeding, which increases our hemorrhage risk. So these moms oftentimes need a little bit more intervention pharmacologically following delivery than a mom who was in labor for a normal amount of time. Okay, because that uterus does not want to contract anymore. It's done. It's like, all right, well, I did my job. Time to clock out, And it's like, no, we still need to get back to our pre-pregnancy size. So let's give you some meds to help you. All right. Um, Hypertonic contractions. So having too many contractions in a short amount of time can is associated a lot with placental abruption, uterine tachysystole, and then if they used cocaine. Okay, cocaine use we know can cause placental abruption, uterine abruption. So this is something that can also send moms into a precipitous labor. All right. But we know that this can happen without warning. Clinicians must be prepared for emergency delivery at bedside, all right, or an RN delivery. But it happens. If a mom has had a history of a precipitous labor, are they at an increased risk of another one with a subsequent pregnancy? For sure. So, and that is something I'm going to tell you guys as a nurse. If you have a mom who calls in and she's like, this is my fifth baby. My last delivery was only 2 hours and I started having contractions like 30 minutes ago. Don't be like, oh, just stay home for a little bit. See what happens. Drink some water and lay on your side, especially if they're term. You're going to be like, I would get your butt in here. And I would call the OB and be like, hey, we have this mom coming in. Because most of the time, if it's happened before, it's going to happen again. Okay. I had a coworker who was triaging a patient, and it was very similar, that type of situation where the mom was like, oh, this is like my third pregnancy. And last time I delivered, I was only in the hospital for like 5 minutes and I had the baby. And she had her on the monitor and she was not really having contractions. She sent this patient home after monitoring her for only like an hour. And the patient came back in 30 minutes later and the baby was like born in the wheelchair on the way to the patient's room. So don't just like blow these patients off. Like we got to listen to them. We got to know like okay, we need to take them seriously and we need to evaluate them for a little bit longer, right? All right. So let's jump over to, we're going to talk about obesity and pregnancy and why this is such a risk factor. So BMI greater than 30 is associated with significantly elevated risks during birth. Okay. From a labor standpoint, in an obese patient, we see them have a lot of more instances of labor dystocia. So that dysfunctional labor, whether that's with our five Ps. Okay. This is just usually it's prolonged. So usually these patients are in labor for a very long time. Okay. And they also usually need augmentation or induction of labor because they're not going to have uterine contractions independently. So these are the patients that we see on Pitocin. We usually have to put them on some type of medication to stimulate uterine contractions. Okay. Um, Obesity and pregnancy will also cause a lot of risk to our infant. So, a big baby is a huge risk factor in an obese pregnancy because, their risk for gestational diabetes is increased in an obese patient. So, with gestational diabetes, we see that macrosomia. We see baby with insulin. Sensitivity. We see babies that need monitoring a lot more after delivery because of this as well. Um, we also, because of the macrosomia, will see shoulder dystocia, other birth injuries that can happen because of this. Stillbirth is a big thing in this patient population, unfortunately, as well as NICU admission. So, when we're talking about stillbirth, right, this can be because of gestational diabetes, this can be because of other maternal complications that are impacting our pregnancy. But another thing which isn't what we think about at first is sometimes these patients have no idea that they are pregnant. Okay. And that's because with obesity our rates of irregular periods are higher. Um, so sometimes these patients who only have a period every 6 months, because whether it's because they are diabetic or they have PCOS or they have an underlying autoimmune thing, if they don't have a period regularly, they're not going to be thinking like, oh, I'm pregnant. That's just their normal cycle. So I've had it before where a mom will come in and they're like, I'm having all this pain, and then they're pregnant, they're in labor. Okay. This is not as common, but it can happen. All right. NICU admission is higher in these patients because of all the things that we talked about: macrosomia, glucose insufficiency, or sensitivity, respiratory distress, because they're in a metabolic state. All that kind of stuff can increase NICU admission. For a delivery risk, they have a higher instance or rate of cesarean birth, and that's usually because they are of the labor dystocia. All right. Wound complications can arise. So, like from a cesarean birth, we need to make sure we're educating those patients on you need to keep your incision clean and dry, especially if they were like have a larger like abdomen. They're gonna need to make sure that they're keeping that incision nice and dry following the surgery. Um, Anesthesia challenges can arise in obese population. Sometimes they may need more. They may not wake up as quickly from a general. There's some complications associated with that. From a postpartum standpoint, these patients are at a risk for a hemorrhage because of uterine abnormality. They're not contracting effectively on their own. It's going to increase their risk of bleeding. They also are at a high risk for venous thromboembolism, so VTEs, infections, and poor wound healing. Okay? So we need to keep all of this in mind and educate our patients very thoroughly whenever they're coming in to have their baby and following. All right, jumping around here. So, has anyone seen or heard of a version or had one done? You don't need to share your story, but These aren't super common anymore, but we still do them. So if you've ever seen a version, it is not the most like graceful looking thing. It actually looks kind of scary sometimes because what the provider does is they usually are doing this. So if a baby is breech, and a mom doesn't have any other type of risk factors, what they will try to do is this external cephalic version, which is when they are pushing on the mom's abdomen to try and manually rotate the fetus into a vertex presentation. So they're taking that breech baby and they're pushing on mom's belly to try and rotate that infant so that they're vertex and then she can have a vaginal delivery. All right. Um, this is all done outside of the abdomen, okay? We are not reaching up into there doing crazy stuff inside. An internal version would be performed only in very rare OB emergencies, okay? And I have never once seen an internal version. I don't even think I could appropriately describe it to you guys because it's done so infrequently. It's like extremely contraindicated for multiple reasons. But the main one we do is this external cephalic version, um, which is in the hopes of getting baby into a vertex presentation. We cannot perform a version on a full term infant because there's not enough space in the uterus to rotate that baby at that point in gestation. So typically you see these versions take place around like somewhere between like 34 to 36 weeks of gestation. All right. Um, how do we prepare for these? So we need to put our baby on the monitor prior to the version taking place. So we do a non-stress test to make sure that baby is doing well. If baby does not have a category 1 tracing, like say their heart rate is dropping, something is looking really weird on the monitor, we're not going to do a version. This baby needs to be in good shape before we are trying to attempt something like this. Okay. We're going to do an ultrasound at the bedside to confirm that baby is still breech, that they even need the version. And then we may administer a tocolytic to relax the uterus. So we may give terbutaline prior to the version to prevent uterine contractions. All right. During the procedure, we're going to be continuously monitoring our fetal heart rate. If mom is Rh negative, they are going to need to get RhoGAM prophylactically because this can cause moms to go into labor. This could cause them to deliver. So we need to be giving this medication prior to this procedure on the off chance that mom goes into labor. So, biggest risk factors with aversion is labor. This can sometimes cause uterine contractions. So, moms are typically observed after this procedure for like a couple hours to make sure that they're doing okay and that baby is fine following the procedure. Okay. Let's see. Okay, yeah, I think that's all I really wanted to talk about with aversion. That's all that you guys really need to know about it. But just know that the biggest risk factor associated with aversion would be labor, sending a mom into labor. All right. Let's talk now about our inductions of labor. So there are different kinds of inductions. And there's different kinds of indications for inductions, okay? So, an induction of labor is whenever we use a chemical or mechanical initiation of uterine contractions before spontaneous onset. So, we are actively putting mom into labor. An elective induction requires a patient to be over 39 weeks of gestation. So, we're not going to allow moms to ask for an induction until they're at least 39 weeks of gestation. Now I know a lot of OBGYNs and a lot of offices are not even offering elective inductions anymore because either they're too busy or they just don't believe in elective inductions. So sometimes they will not do inductions until a mom is 41 weeks. Okay. The one of the things that you guys will need to know in regard to induction of labor, especially for your exam, is the Bishop score. So, a Bishop score is going to evaluate cervical inducibility. So, is the cervix favorable and is an induction going to be successful? Okay. It's a scoring system that is looking at a couple of different things that we'll go through here. And a score of 8 or more is considered favorable for induction. Okay. So, it's looking at, is the cervix soft? Is the baby's head down? Is the cervix dilated? Um, Let me pull up an actual example here. I don't think you guys, for the purpose of your exam, need to know exactly all of the different categories, but I want to tell you what we um, are looking at. So it's looking at the baby's position, the position of the cervix. Is the cervix posterior, middle, or anterior? If the cervix is anterior, it's at the front. That's going to give them a higher score. Is the cervix soft? How effaced is the patient? Is the cervix? What is their dilation, and how low is the baby's head? That's the kind of stuff we're feeling. So it's basically from a cervical exam is how we're going to get our bishop score. Um, so if a patient comes in and they're like 40 weeks and they're like, I'm really tired of being pregnant, I really want to have an induction, and their bishop score is a 6, that is going to be up to the OBGYN if they're going to do an induction or not. Okay. I've had patients who come in and their bishop score was like 2 and they're doing an induction. Okay. So it's not like they're going to just say, oh, your score is not an 8. We're not doing an induction. It just means that the likelihood of a vaginal delivery is a lot higher if they have a favorable bishop score. All right. So, how are we going to do an induction of labor? What are our methods? So, cervical ripening methods is one of the ways that we are going to send a mom into labor or do an induction. From a chemical standpoint, this would be our medications that we're going to give them. So, the biggest group of medications that we give for an induction would be prostaglandins. Okay, this is Cytotec, Cervidil, prostaglandin gel. What we do is we usually apply these up by the cervix. All right, so for Cytotec, you would take however much it is, it's usually not very much. You would perform a cervical exam and you would place that pill right on the outside of the cervix. It helps soften the cervix. It's more of a gentle introduction into labor rather than just like jumping into Pitocin. It's more of a natural progression into an induction. Um, it does start some uterine contractions, but it softens and ripens the cervix for effective dilation. A mechanical standpoint, so this is like a Foley balloon. This is what happens when we place a Foley catheter up into the uterus. We inflate the balloon with some water, and then we pull on that balloon, and it just sits right on the cervix and mechanically dilates that cervix. All right. Foley balloon typically will get a patient to about 4 centimeters before it falls out. And from what I've heard, I've not experienced it myself. What I've heard is a Foley balloon really sucks. Like these patients do not like it. They do not have a fun time with a Foley balloon, and usually they are pretty uncomfortable by the time that thing has popped out. Laminaria dilators, I do not see that used very often. Honestly, when we talk about mechanical ripening methods, the Foley balloon is the most common. From a physical standpoint, we can encourage a patient to have sex. Having sex can sometimes send a patient into labor. That is one of the things we tell moms, especially if they're post-dates, to try having sex, because not only is the active sex going to stimulate labor, but semen up near the cervix can stimulate labor and cause the cervix to dilate. Nipple stimulation is another one. They can do that at home or at in the OB unit, we can have them pump. So sometimes we put them on the breast pump and we'll monitor them because pumping can stimulate uterine contractions. All right. Getting up and walking, curb walking, sitting on a birthing ball, doing the like curb walks, whatever, all those like little things and tricks that everybody talks about. Those would be the physical things that patients can do on their own when they're not even in the hospital. And then finally, an amniotomy. So, this is when a provider goes in and artificially ruptures the patient's membranes to try and stimulate uterine contractions. All right. This is my least favorite induction method because some providers like to rupture a patient's membrane when they are like 1 centimeter and that baby's head isn't fully down on the cervix and they have a lot of amniotic fluid. So then I'm just sitting there like, hopefully we don't have a cord pop out. We don't want to see a cord prolapse. The risk of cord prolapse with an early amniotomy is extremely high. So we need to be sure that we're prepared for that as the bedside nurse if a provider wants to go and rupture membranes. Okay. Any questions about this? Okay. Another medication that we're going to talk about a little bit more in depth here is oxytocin. This is something that we're going to use to stimulate contractions. It's used in both in labor and then also postpartum. But during labor, it's a much, much, much smaller dose given IV to stimulate uterine contractions. Okay. So, what is this medication? What does it do? It is a hormone that is produced from the posterior pituitary gland, and it stimulates uterine contractions, and it also helps with milk ejection and our lactation process. We use the synthetic form to induce or augment labor. It has a short half-life, so it's only 10 to 12 minutes, and it's dosed in milliunits per minute. So, for example, a typical order that you would get from a provider is, all right, let's go ahead and start this patient on Pitocin. I want it started at 2 milliunits per minute, increased by 2 every 30 minutes until we have a regular contraction pattern. All right, so it's a very, very low dose. There's not very much oxytocin that we're giving during labor to stimulate uterine contractions. You really do not need very much for it to be effective. Okay. Um, Usually, a steady state of Pitocin is reached after 40 minutes. Okay. So I really despise when I get an order from a physician and they're like, all right, let's start the Pitocin at 2 milliunits and let's increase it by 2 every 15 minutes, right? Because that's fast. That is increasing Pitocin very, very quickly. That runs our risk of uterine tachycystole, that increases our risk for uterine rupture. The patient's not going to feel very great on that because you're introducing so much of this medication all at one time. Um, so usually I will just do every 30 minutes or even a little longer. Like you don't want to be bumping this Pitocin up too quickly because that can pose so many risks to the baby and the mom. Um, so, what are some adverse effects? The biggest risk with Pitocin use is uterine tachycystole and uterine rupture, right? Because if we're introducing this medication too quickly, we're having too many contractions, that's going to cause a uterine rupture, or it's also going to we're going to see potentially placental abruption, which can lead to unnecessary cesarean birth, right? If you're introducing this medication too quickly to this patient and all of a sudden the baby starts having um, a decrease in their heart rate or they're having abnormalities in their heart rate and mom isn't tolerating this well and we're seeing hypoxia, that can indicate to a provider, oh, we need to have a C-section when it's realistically like, why don't we just bump our Pitocin back? Let's slow down this medication, give this baby some time to recover, and then restart it if it's appropriate later in the day. And that is why, as a bedside nurse, you need to be comfortable running this medication and being able to analyze signs and symptoms of uterine tachycystole because we don't want our patient to have a cesarean delivery simply because we ran our Pitocin too high. Postpartum hemorrhage is also common following oxytocin use because oxytocin is causing uterine contractions. If you are on prolonged use of Pitocin, that increases your risk of hemorrhage. Okay, because your uterus is not going to contract very effectively on its own. We're going to need to give even more of this medication, and it can cause uterine dystocia or problems with postpartum uh, hemorrhage. So, like I mentioned, fetal hypoxemia and late decelerations, and this is because of uterine tachycystole. All right. Just because we have Pitocin in does not mean like our baby all of a sudden is going to take a dive. There has to be a reason why we are in a hypoxic state, and oftentimes, from a fetal standpoint, it's because we are having too many uterine contractions, and baby does not have enough time to recover in between. All right. So that is why in the order set, it usually says run the Pitocin until you get to a uterine pattern of contractions every 2 to 3 minutes because we still want baby to have that appropriate time to recover. Okay. We also can see infection with this, and that is just because of our standard labor patterns and labor process. Oxytocin is among the drugs most commonly associated with adverse events during birth, so we need to make sure we're monitoring this very closely throughout administration. Oxytocin is also a high risk medication, so whenever you're starting this in the labor and postpartum period, you have to have another nurse at the bedside signing off with you to check your pump, check and make sure you're running everything correctly. Okay. Um, this wasn't at my hospital, but there was a hospital like close to ours where a nurse messed up her pumps and bolused in Pitocin rather than bolusing in fluid, and patient's uterus ruptured. They had to go back for a stat C-section. Mom was in the NICU. Well, mom was in the ICU. Baby was in the NICU. It was this huge adverse effect. So now a lot of hospitals are requiring their nurses to label their pumps and label their tubing, which you should be doing it. That's what I've done, but now it's pretty much required because of that effect. So we need to be really careful when we're administering these types of medications, especially during labor. All right, augmentation of labor. So, augmentation refers to stimulation of uterine contractions that have already started spontaneously. So, mom is having contractions on her own, but they're either not strong enough, they're not happening as often as we want them to, they're not long enough, or they're not intense enough to produce cervical dilation and fetal descent. So, we're going to be adding in medication or other types of induction methods to augment this labor. So, indications could be uterine dysfunction. Like I said, mom's not having enough contractions on her own. The contractions aren't strong enough. They're not long enough. Either she's been in labor and it's stopped all of a sudden, like her contractions just stopped, or we're just not progressing. Okay. So the most common augmentation method is starting Pitocin. Okay. The next one would be rupturing membranes, so artificial rupture of membranes to stimulate contractions. And then sometimes we can use nipple stimulation in a low risk setting. To be completely honest with you, the nipple stimulation thing is something we may use if a patient doesn't want Pitocin and they're like, can we try something else before we do Pitocin? And it's like, sure, we can pump for an hour or two and see what happens. But most of the time in an augmentation setting, we're going to need Pitocin. Um, what we need to consider with these is we are always going to be monitoring our fetal heart rate. Anytime we are introducing medication or induction or augmentation methods, these infants need to be on the monitor, okay? Because we need to assess for tachysystole, which is whenever we have more than 5 uterine contractions in 10 minutes. And then obviously, like I had mentioned, we need to be titrating our oxytocin per protocol. If you're running Pitocin and your baby starts having recurrent late decelerations, what should your first intervention be for that patient?
Maybe stop the Pitocin.
Yeah, you need to stop the Pitocin. All right. If you like, if you have a patient and that baby starts like looking like crap on the monitor and you call the provider and you're like, I did all my turns. She's on her left side. I gave a fluid bolus. She's on oxygen. Um, all that stuff, but you didn't turn your Pitocin off, they're going to be like, yeah, you need to shut your Pitocin. That is always the first thing you should do if you're running Pitocin. Okay. That is why a lot of providers prefer to use oxytocin rather than Cytotec whenever we're doing inductions because oxytocin you can stop. If you place Cytotec vaginally, you can't take that away, right? So if a patient has too many contractions with Cytotec, you're kind of just like having to give fluid and turn them and do all these interventions when realistically we just should have not placed the Cytotec, right? So Pitocin's a little bit better in that aspect because you can shut it off and it has a very short half-life, so it's out of the system pretty quickly. All right. Vacuum assisted birth or a kiwi is sometimes what it's called, a kiwi delivery. This is what happens when there's a vacuum cup applied to the fetal head, and it assists with delivery. So you can see in this diagram here. So usually what happens is either mom's pushing is not effective, or we've been pushing for a really, really, really long time, and mom is exhausted and doesn't have the power in that stage of labor. So we're going to need to help her a little bit with delivery. Or if baby's in a funky position, sometimes providers will put the vacuums on to try and maneuver baby's head in the pelvis as the baby is being pushed and delivered. So we apply this suction cup to the baby's head. We apply some negative pressure. So usually the providers like pump the suction to like create more of a seal on the baby's head. And then they pull as the mom is pushing during a uterine contraction to pull baby out. Okay. Um, as you can imagine, this will have some potential risk factors for the baby as well as the mom. So, our requirements with the Kiwi delivery, mom obviously needs to be completely dilated. We need to have no cervix left, right? We're not going to have a cervical laceration because of a Kiwi. Like if mom isn't fully dilated and they're suspecting that they need to have an assisted delivery, we're probably going to have a C-section. Okay, the head needs to be engaged. Obviously, it needs to be vertex, so we're not going to be doing a Kiwi on a breech delivery. Mom's water needs to be ruptured, and then no suspicion of cephalopelvic disproportion. Okay, so we need to be certain that this baby can deliver vaginally right before we start pulling on its head. From a maternal standpoint, the risk for mom would be lacerations. We also increase her risk of having a hematoma following birth. For baby, this is more common. We see more fetal risks associated with vacuum assisted deliveries than moms. We could see some cephalohematomas. We occasionally will see subdural hematomas. The baby might have some lacerations on their head from where the Kiwi was pulling. If it's severe enough and we caused enough neurological damage, baby could have some seizures. The baby also will be susceptible to hyperbilirubinemia, and that's simply because anytime there is some type of injury to the baby, like bruising, lacerations, what have you, their instance of having jaundice is a lot higher because of the mechanism of healing, the healing process for an infant. Okay. Babies with this kind of delivery, we expect to see some swelling. We expect to see some molding on the head. We expect to see a little bit of asymmetry. That is okay, all right. But if there's a cephalohematoma or a subdural hematoma, that needs to be evaluated pretty quickly, all right. A forceps assisted birth is another type of assisted vaginal delivery. It's indicated for moms that are in a prolonged second stage of labor. If we have babies showing signs of distress, if baby is presented, or they've stopped like rotation, or they're not descending as effectively, this is what we can use as well. Forceps are not used as commonly because the risk factors for baby is a little bit more increased than a Kiwi delivery. It's a little bit more traumatic of an assisted birth, so we try to use this as sparingly as possible. For moms, we can see some increases in lacerations, urinary retention, and hematomas. And then for babies, we can see bruising, abrasions, sometimes facial nerve palsy, and then subdural hematomas. So what they do is they take these forceps and they place them on either side of the baby's head, and then they help pull as the baby is coming down through the vaginal canal. So it's usually I think they're teaching this to providers again. There was a period of time where they weren't even instructing providers in this method of delivery. It kind of went to the wayside. They were using mainly the Kiwi deliveries. But now they're reteaching it again in medical school, so we'll be seeing this a little bit more. All right, amniotomy or a artificial rupture of membranes is performed using an amni hook, which is just like a little. It literally just looks kind of like chopsticks with a little hook on the end of it, where the provider will perform a cervical exam. They'll pass the amni hook up into the cervix, and they'll rupture the bag of water using that hook. Before this happens, we need to confirm that baby is head down and that the head is engaged before the procedure to help reduce the risk of a cord prolapse. We need to assess our fetal heart rate immediately before and after to detect if there has been a cord prolapse. If we have the baby on the monitor and everything looks good, 20 minutes before they break water, baby's heart rate looks good. And then all of a sudden, we have a prolonged deceleration following amniotomy. We can be safe to assume that we had a cord prolapse and we need to prepare for a cesarean section. Anytime a provider breaks water, it's the nurse's job to document how much fluid has come out, what the color of the fluid is there any odor, is it purulent, is it clear, what does our fluid look like? And then we need to continuously monitor for signs and symptoms of infection following the procedure. As soon as a patient has had their water broken, they should be on the monitor to continuously up until that baby is delivered. Okay, we are not going to be intermittently monitoring this heart rate of the baby. They are going to be on the monitor the entire time. Okay. All right. C-sections. Let's talk about C-section. This is when we have an incision of the uterus performed to preserve the well-being of mom and fetus. C-sections can be elective, scheduled, or unplanned depending on clinical indication. So, common indications of a C-section. Why would we have a scheduled C-section? Um, or like one that we may need to do medically aside from it being a repeat. If baby has Marfan syndrome, if we have a known diagnosis of Marfan syndrome, we need to do a C-section. If mom has a placenta previa, she obviously cannot deliver vaginally, so we need to have that as a scheduled C-section. Or if baby is breech, a malpresentation would be cause for a scheduled C-section. All right. Um, Risk factors associated with C-section. The biggest one is an infection, right? It's a major surgery, so we have a risk of infection. Injury to adjacent organs. So typically, if we see any of the organs or anything injured, it would be like sometimes bowel, or I've seen a bladder perforation, unfortunately, one time, and then any type of embolism. All right. From a fetal standpoint, birth injuries can occur with a C-section, asphyxia, and then respiratory compromise. So, with C-sections, babies born via C-section are at a higher risk for respiratory distress rather than a baby who has had a vaginal birth. So, why is that? So, as baby is coming down through the vaginal canal, they are being continuously squeezed, and there's going to be pressure put on the baby as they're making their descent in the vagina. That squeezing motion is helping them eject fluid from their mouth as they're coming down through the vaginal canal. So, after a vaginal birth, they do not have as much fluid in their mouth because of that squeezing method, because of the uterine contractions and the pressure that's being placed on the baby. With a C-section, that pressure is not occurring because they're not passing down through the vaginal canal. So babies are going to be swallowing fluid and they're not going to be able to eject it as easily because that pressure from the uterine contractions is not taking place. So we see them have a little bit more aspiration. Their lungs are usually a little bit more gunky. We have crackles or diminished lung sounds more often in babies with via C-section. So it's just because of the mechanism of delivery. All right. So that's something to keep in mind. With a C-section, the anesthesia options are typically a spinal if it's scheduled, an epidural if it's happening after or during during labor. So she's tried to deliver vaginally and we have to convert to a C-section. Or in the most severe cases, we put the mom under general anesthetic, and that is for a stat C-section. That is when we are performing an emergency C-section. We typically are doing a general. General anesthetic is usually it is reserved for emergencies because as soon as you give a mom general anesthesia, the oxygenation to the placenta and the uterus is immediately stopped. Okay, so that baby needs to be delivered within 2 minutes after the mom is put under a general anesthetic. All right, we need to get that baby out immediately. Cesarean births can be performed electively, but that is at the discretion of the OBGYN. So if a mom asks for a C-section rather than trying to go into labor and have a vaginal delivery, that is something that can be discussed between her and her provider. All right. Which I have seen that, I know, and it's per patient discretion. Something I've seen a lot for an elective C-section was one time I had a patient who had an extremely traumatic first birth, and she was so anxious and worried about her delivery to the point that she decided having an elective C-section would be better for her. Okay, so there's all sorts of situations that can happen that a patient may request or ask for an elective C-section. Surgical incision techniques. This is very important to understand with a C-section. So there's two primary skin incision approaches that are used for a C-section. They're each performed for for specific clinical indications for in the respect to healing, future pregnancies, surgical access. So a vertical or a classical incision, we do not see this very often, all right? If we are doing a vertical or a classical incision, it's usually because this baby needs to be delivered right now. Like we're doing an emergency stat C-section because there was an abruption, because something happened in utero, something is going on that we need to get access to this baby immediately. So this is a vertical or classical incision. It goes straight down vertically from the mom's umbilicus to the top of her pubic bone. Like I said, it allows rapid access. So this is the fastest way to perform a C-section. But it has a high risk associated with uterine rupture in future pregnancies because of how that scar heals. And it's also contraindicated for a VBAC. So if a patient has had a classical incision, they are not a candidate to deliver vaginally following the C-section. All right. And we need to know that. A low transverse incision, I'm not going to try and say that word there. This is a normal incision that runs horizontally along the first skin crease under the hairline of the pubis. It's the most common approach. It's associated with lower blood loss, reduced risk for uterine rupture and subsequent pregnancies, and it also is more preferable from a cosmetic approach. Like moms usually prefer to have this. It's a little bit smaller. It's usually you can hide it under like underwear or like a bathing suit bottom. It's not as like large of an incision. Okay. If a patient has had a low transverse incision, she is a candidate for a VBAC. She can try and deliver vaginally if it's appropriate and if the provider agrees in a subsequent pregnancy. Okay. So, for a nursing care standpoint, in the perioperative phases, so intraoperative, we are going to be helping position the mom on the OR table. We're going to be monitoring or helping monitor the baby, maintain sterile field. We probably will be inserting a Foley catheter because she won't be able to get up and move for about 5 to 8 hours following the surgery. After the surgery, post-operatively, we're doing the recovery periods, we're doing vital signs, we're doing fundal checks, we're doing pain management, all of that stuff, Q 15 minutes. Um, and then in the post-op and postpartum period, so before mom goes home, we're helping getting her up. We're moving her to the chair. We're helping make sure that she's passing gas, making sure she's able to tolerate fluids and food, helping with breastfeeding. We're doing discharge teaching. We're helping with all the postpartum care for moms before she goes home. Um, we need to make sure in this with these patients that yes, we did a surgery. Okay, so the likelihood of retained placenta or retained product is a lot lower than it would be with a vaginal delivery, but it still can happen. So we need to make sure we're assessing uterine tone, vital signs. What does mom's bleeding look like? How is she doing following the procedure? All right. So, a TOLAC or a trial of labor and vaginal birth after cesarean is what we do to determine if mom can have a vaginal delivery following a cesarean delivery with her previous pregnancy. So, a TOLAC is trial of labor after cesarean. This is when we observe the mom and fetus over a specified time to assess if this is going to be something that she can do. Is this going to be a possibility for her? All right. It requires continuous fetal monitoring in a facility capable of emergency cesarean section. Okay. VBAC considerations. Who is a candidate for a VBAC? Primary indications often do not reoccur. So, like, if mom had a C-section before because she was breech, or there was fetal distress or labor dystocia, all right. She's at a very low risk for uterine rupture with this kind of history. So this would be a candidate. This mom would be a candidate to try a VBAC. It is contraindicated in a patient who's had a previous T-shaped uterine incision or a classical incision. All right. or if mom has a history of uterine rupture. If mom has had a uterine rupture in the past, she should not be trying a V back. Okay, so that is something that we need to make sure our patients are aware of. And we're making sure that we know about that if it's in mom's history. All right. And another OB emergency we need to talk about is if there is meconium stained amniotic fluid. So, meconium in the amniotic fluid indicates that the baby had its first bowel movement in utero. And so it's going to look like green or brown or sometimes even really dark black tinged amniotic fluid. All right. What causes a baby to have a bowel movement in utero? Physiologic maturity. So, normal GI function in a term or post-term fetus. So we see this a lot in babies that go post-dates. Okay. The risk for this increases obviously with gestational age. Another thing could be hypoxia induced. So there was some type of stressful event that reduced the oxygenation to our baby that caused them to have this type of reaction. So they ended up having a bowel movement in utero as a result. Hypoxia triggers peristalsis and anal sphincter relaxation, causing intrautero defecation. This is a warning sign of fetal compromise. So if I have a patient who has meconium stained fluid, that is indicating to me that there was some type of stressful event that had taken place to cause baby to have a bowel movement. All right, so this baby is already a little bit stressed out. And then the last thing is vagal stimulation. So umbilical cord compression, okay, could cause meconium passage. So in this instance, it could be babies having variable decelerations or some type of decelerations indicating that they are having compression on the umbilical cord, causing them to have a bowel movement. All right. The primary risk associated with this would be meconium aspiration syndrome. So this is a type of pneumonia that babies can have following delivery. All right. So from a nursing bedside nurse standpoint, if you see meconium stained amniotic fluid, you need to make sure you have a NICU team at the bedside when the baby is delivered. Okay. Have the appropriate personnel and providers at the bedside so that we can provide quick care for these infants. All right, let's talk a little bit about shoulder dystocia. I'm not going to spend too much time on this slide because we've talked about it quite a bit over the last 2 weeks. We know what this is. This is when that anterior shoulder gets stuck under mom's pubic bone. The head is delivered, but the anterior shoulder is not. This is identified by the turtle sign. You guys need to know that. The turtle sign. This is what happens when you will see baby's head is delivered and it will peek out and then come right back. And then it'll kind of come out and then come right back. Okay, that's what we call the turtle sign. This is retraction of the head against the perineum, and it's something that can indicate that there is a shoulder dystocia. We know what our risk factors are. Okay, be familiar with that. And we know the complications. The biggest one is fetal asphyxia, clavicle fractures, brachial plexus injury, for mom, perineal trauma, rectal injury, and hemorrhage are big ones. All right. Managing shoulder dystocia. So this is what I was talking about last week when I mentioned McRoberts maneuver. This is when we're going to take those mom's legs out and then shove them back as quickly as possible. So you'll have a nurse on each side of the mom, and one nurse will have one leg, the other nurse will have the other. This helps rotate that pubic bone to widen our pelvic outlet and allow that anterior shoulder to be released and delivered. All right, that is our first line intervention. The next one we'll do is apply suprapubic pressure. So that's when a nurse or the provider, I guess, will apply firm downward pressure just above the pubic bone to basically shove that anterior shoulder out from underneath. Okay. And then finally, we have our Gaskin maneuver, which is when we reposition the patient to hands and knees. They're on all fours. And this uses gravity to free that shoulder. So usually we do McRoberts first, with or without suprapubic pressure. And then if those two don't work, then we put them in hands and knees. If we're getting to Gaskin maneuver, you should have somebody in the OR opening for a C-section, right? Because we don't want to allow the shoulder dystocia to go on for a prolonged amount of time because it increases the risk for baby to have some type of respiratory distress. All right. Cord prolapse is like the scariest thing ever as a bedside nurse, honestly. That's what happens when the cord is delivered before the presenting part. So our cord is in the vagina, it's in the vaginal canal, it's being exposed to air before the baby's head is delivered. All right. Um, so these are some things that can contribute to a cord prolapse. If we have a long cord, if babies breach because they're not engaged correctly, or if they're having a variable or prolonged deceleration during uterine contractions, that can indicate that we've had a cord prolapse. All right. What do we do as the bedside nurse? And you guys need to know this. You stay with your patient. You do not leave that room. You're staying there. You're calling for help. You're going to put a sterile glove on, okay? You're going to make sure that mom is in some type of hands and knees or position like this over here, need a chest position to use gravity to shift that baby down and out of the pelvis, all right? You're going to put pressure on that presenting part to lift that part up off of the cord so that we're not putting any pressure on that umbilical cord. You'll put them potentially in extreme Trendelenburg, modified Sims, or knee chest position. Um, you can wrap the exposed cord in warm, sterile saline towel. Usually, you're not the one doing this because your hand is actively releasing pressure off of that. You won't be able to do this. So your other nurses in the room should help you with these things. You're going to give mom oxygen. You're going to start a fluid bolus. You're going to monitor baby's heart rate, and we are going back for a C-section. Oftentimes, that nurse that has their hand up, really relieving pressure, is being wheeled back to the OR on the bed with the patient. All right. So this is something that you're going to maintain that position up until mom is on the table and we're doing a general anesthetic and we're getting that baby out immediately. Okay. So this would be an instance where we are using general anesthesia. This is a stat C-section. This is an emergency. All right, uterine rupture obviously is another OB emergency. This is rare but life-threatening. Happens whenever there's a separation of the uterine wall layers. Most of the time, it's caused in a patient who's had a C-section in the past, and the rupture occurs on their scar from their C-section. So scarred uterus, a multiple C-section history is a risk factor if they've been pregnant a lot, if they're grand mal tips. Or uterine overdistension. So big babies, multiple gestations, polyhydramnios, anything like that can lead or increase our risk for uterine rupture. Any type of trauma can also cause uterine rupture. So we can prevent by not allowing patients that have had those classical incisions try to have a VBAC. We want to monitor our oxytocin administration and prevent any type of uterine tachysystole. Um, and then our management depends on the severity. So if it's a very, very small tear in the uterus, sometimes we can monitor these patients, but oftentimes we're going to be delivering. Okay. The amniotic fluid bolus, which I had mentioned whenever we were talking about C-sections, is an anaphylactoid syndrome of pregnancy. So this can occur during labor, birth, or within 30 minutes after delivery. What would happen? The mom is going to present with respiratory and cardiovascular collapse. She'll have extreme hypotension and hypoxia, and she'll start going into DIC. All right. What puts patients at a risk for an amniotic fluid embolism? If they have rapid labor, so a precipitous labor, meconium stained fluid, sometimes labor induction and augmentation can be predisposing factors, and abruption or previa, and then a lot of fluid, eclampsia, or post-term pregnancy. So, like any type of like risk factor can lead to an amniotic fluid embolism. We need to initiate CPR immediately. These patients are going to arrest. If mom has passed, we need to do a cesarean within 4 minutes, okay, if we're not able to revive mom. So this could be a bedside, this could be in the ER, whatever it may be. This will optimize fetal survival and will facilitate maternal resuscitation to deliver the baby, okay? All right. So let's see. Next week, let me see, where are we right now? All right, so we can do some practice here really quick because we've got like about 10 more minutes. So for labor dystocia, the nurse is monitoring a client who is in the active stage of labor. The nurse documents that the client is experiencing labor dystocia. The nurse determines that which risk factors in the client's history place her at a risk for this complication. Select all that apply. What do you guys think?
Definitely number 4.
Mm-hmm.
54 years old?
Yeah, I was looking at that. I'm like, wow, that is a very old older pregnancy. So we got age 54, body mass index of 28, previous difficulty with infertility, administration of oxytocin for induction, and a potassium level of 3.6. So I would agree with you on the number 1 and 4. Let's see. 1, 2, and 3. So an age of 54, so advanced maternal age is definitely a risk factor. BMI of 28 would be classified as overweight, which can increase our dystocia risk. They're not in that obese category because it's not over 30, but they're still overweight, so we can use that as a consideration. And then prior infertility is directly listed as a dystocia risk factor, okay? Because we did talk a little bit about maybe assisted reproductive technology or like IVF can cause like some dystocia in labor. So oxytocin use alone is not a risk factor. I guess only uterine hyperstimulation is. So I guess like if we were having too many uterine contractions, maybe then. And then a potassium of 3.6 is within our normal range. Okay. So then over here we have the risk factors for labor dystocia listed again. All right. The nurse in a labor room is preparing to care for a client with hypertonic uterine contractions. They're erratic in frequency, duration, and intensity. What is the priority nursing action?
Provide pain relief.
So let's see. We're worried about hypertonic uterine contractions. I think, yes, we are going to provide pain relief. So hypertonic contractions are painful, frequent, and uncoordinated. The primary intervention is pain relief to promote a normal labor pattern and allow the uterus to rest. So, amiotomy and oxytocin are going to be used for hypotonic dysfunction, not hypertonic. So, those are things that we're going to implement if we want to have more contractions. Ambulation would be contraindicated because we want our patient to rest. Okay, so we want to make them comfortable and provide some pain relief to allow some rest and allow this uterus to recover. Next question. The nurse is performing an assessment on a client who has just been told that a pregnancy test is positive. Which assessment finding indicates that their client is at risk for preterm labor?
B2.
Yes, they have a history of cardiac disease. So, preterm labor can occur after the 20th but before the 37th week. A history of any type of medical condition is a recognized risk factor. So, this can compromise uterine perfusion and trigger early labor. All right. So, why are the other options not right? If they're 35, the elevated risk begins whenever they're older than 40 for a first pregnancy. Hemoglobin of 13.5 is normal. And then age 20 and average weight is not really a risk factor. That's normal pregnancy. All right. The nurse has created a plan of care for a client experiencing dystocia. What is the priority nursing action?
Monitoring the fetal heart rate.
Yes. So fetal status is always going to be our priority with dystocia or with really any other type of labor. Okay. So we really want to make sure that our baby is tolerating labor, especially if we are not having a very adequate one. So as far as the others, for comfort measures, it's important but secondary to fetal safety. Position changes again, helpful but not the priority. And then family communication is holistic care, but it's not the priority. We need to prioritize fetal safety. All right. So here are our nursing priorities in dystocia, monitoring fetal heart rate. Then we can maybe provide comfort and pain relief, then reposition the client and keep the family informed. All right. So we know what our assignments and stuff are for this week. I'm going to stop sharing my screen here. Get out of that. All right. So, if you guys are good, we're gonna end class now because we didn't take our break. I'm gonna stop our recording.